Hello, good afternoon. We've got 2:01 and let's get started. Welcome everyone. We'd like to go ahead and call the Health and Hospital Committee meeting to order at this time. I'm Supervisor Otto Lee, Chair of this committee, along with my Vice Chair, Supervisor Margaret Abe Koga. And with both supervisors present, we have a quorum. Moving to public comment, which is item number 2, reserved for members of the public to address the committee on items that's not on the agenda, so that any public that would like to speak on an item not on the agenda today should request to speak at this time. So how many cards do we have, Jess?
For this item, we have one request on Zoom.
One, okay, 3 minutes, please.
Okay, we'll change the timer to 3 minutes. Our speaker is Parent. We'll open your microphone. And you'll have 3 minutes to speak.
Yes, thank you. Good afternoon to you all. I previously requested help for my children to get a screening because they're being sexually molested. My son, he's already confirmed that my ex-wife was letting a man anally rape him beginning at the age of 13. There have been unnecessary bathing with an adult and 2 of the children. And also there was sexual contact between 2 of the children, and one child rubbing his pelvic area against the rectum of another child, and I had to separate them several times. It's apparent to me that all 4 of them were being sexually molested, and I can't get a screening for my kids because my former attorney, she wants the sexual abuse to continue, and apparently it's a conflict of interest with this county, and now this person she's threatening to kill my kids if I don't stop trying to protect them. And this person is completely deranged. She's caused me great bodily harm over this, and I have death threats all the time, and I'm being stalked and hacked. And I mean, this woman is completely insane, and I can't believe that I can't get my kids a screening. I mean, she's threatening to kill my kids. I mean, you guys can see this. I forwarded it to Otto Lee too. If you Google Valerie Houghton shoes, and that's Houghton, you'll see a blog called Making Shoes. And I posted the links, the direct links to her threats to kill my kids and make shoes out of their skin. I mean, she's crazy. This woman is crazy. I can't believe she's not locked up. She's done this to so many other parents. I mean, you could see what happened to a lot of different parents, and I'm not going to name the names right now. And I beg you guys, please, is there somebody here who can help push a screening for my kids? Because, I mean, once a child says that he's been raped, I mean, that's when you go in and you do a screening, and especially when some crazy lunatic is threatening to kill my kids. I mean, you go and you do a screening. I can't believe that I'm having to come to this public meeting and beg you guys to help my kids. Please. Thank you for your time.
That concludes public comment.
Thank you, Jess. The announcement I want to make is basically that California law does prohibit the disclosure of information relating to investigation of suspected child abuse. As a result, we are not authorized by law to speak to the specific of any particular case or the results of investigation in the case, even when the allegations are made part of the public comment. The law requires child welfare departments to immediately cross-report physical and sexual abuse of children to law enforcement and district attorney's office so that swift action can be taken. The public can be assured that our county do take these allegations very seriously, and this includes rapid cross-agency responses by the Department of Family and Children's Services, our local law enforcement, the Child Advocacy Center, and the district attorneys. We also do have a complaint page provided by the California Department of Social Services that provide guidance on various avenues by which someone can make a child welfare-related complaint. When a speaker's comments also reflect concern of the family court, the complaint page provides direction on submitting a complaint when there is concern about a California judge's performance as well. All right, then that's all we have on item number 2. Moving to item number 3, which is the approval of the consent calendar and changes to committee agenda. I actually have one item to see if it's okay with my vice chair for item 7, whether we can add that one, which is relating to the Public Health Department report on epidemiology grants and contracts for the care of STIs. Is that okay? To the consent.
Oh, to consent, yes.
Yes, okay, all right, thank you. Do you have any other changes to consent?
No.
Okay, first, let's see, any public would like to speak on any consent items, Jess?
Chairperson, I'd like to flag, I'm having trouble hearing you.
Oh, I'm sorry, I'll
And-
get closer.
Thank you. And I'm confirming no request to speak on the consent calendar.
All right, thank you. May I entertain a heavy motion?
Yes, I'd like to make a motion to approve the consent calendar, item 12 through 20 plus 12 through 20 plus 7.
For 7, okay, very good. And I will second that. Let's take a vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
I as well, thank you. And now moving to item number 4, which is receiving report relating to the role of Santa Clara Valley Healthcare as a safety net healthcare provider and fiscal review of SCVH. And Paul, all yours.
Great. Thank you, Chair Lee. Supervisor Abekoga. It's a pleasure to be able to speak to this item again. As you recall, back in January, we did have a study session for which we spent most of the time talking about the impacts of H.R. 1, as well as talking about other implications within the healthcare market here in Santa Clara County. As a reminder, Santa Clara Valley Healthcare is looking at a $1 billion shortfall in revenue due to H.R. 1 when all of the provisions of H.R. 1 are implemented. This year alone, the Santa Clara Valley Healthcare was looking at $200 million. We came to the board at mid-year just recently for your board to approve budget solutions in order for us to get to year-end on budget, but also to prepare us for the 26-27 budget. In 26-27, Santa Clara Valley Healthcare is looking at a $160 million shortfall. I think, as reported by James Williams, the county overall is looking at a $400 and some million shortfall in terms of the overall county budget. This is after the inclusion in accounting of the $330 million from Measure A. So as you can note, we are still confronted by some major challenges relative to our budget. During that study session, we did take the time to talk about how we are going to address the deficit and the shortfall. We are looking to maximize revenue as much as possible. The reality is that we are not going to cut ourselves to $200 million in shortfall in revenues, nor are we going to address our shortfall in 26-27 by simply cutting costs. So the $200 million that we presented to the board recently represented about $50 million in revenue solutions, with the other 50% coming from cost savings. As part of that cost savings, the healthcare system identified 218 positions, of which 40 positions were filled. So we are at the point in time in which, as much as we have attempted to look at vacant positions, we are now cutting into filled positions in order to balance our budget. The good news is that those individuals will have a place to fall somewhere within the healthcare system. So they will not be laid off, but they will be carrying out other functions within our healthcare system. So with that being said, what I'd like to do is focus today's session on 2 areas. One is how we are looking to adopt AI, artificial intelligence, to help leverage our technology and capabilities, but also talk a little bit about our revenue cycle process and as we look to improve our revenue picture and portfolio going forward. So at this point in time, I'd like to introduce Khalid Turk, who is the Deputy Director with our Technology Services Support Department, who will talk about our work around artificial intelligence, and then we will turn it over to Vinod Sharma, our Chief Financial Officer, to talk about our revenue cycle improvements. Khalid, I turn that over to you.
Thank you, Paul. My name is Excuse me, my name is Khalid Turk, and I'm here to present about the implementation of AI at Santa Clara Valley Healthcare. Santa Clara Valley Healthcare, as we all know, uses Epic EMR. So our AI capabilities and AI enablements surround around our EMR. And they are categorized in 3 different buckets, if I may. We focus on the clinical workflows, patient access experience, and revenue cycle. Essentially, our vision here is, while working with the provider leadership and administrative leadership, to enable providers to maximize their efficiency and at the same time address the burnout where possible. From the patient access experience, we are using AI-enabled functions where patients can interact with their care providers more efficiently, and we're going to talk about that in a while. Then in the end, is the third bucket is the revenue cycle. And at the revenue cycle, we are utilizing AI both provided by Epic, natively in the Epic EMR, as well as we are also exploring some external solutions, currently just exploring them to make sure that we can enhance our revenue where possible. Next slide, please. Since AI is a newer technology, we are making sure that we implement it the right way. And in order to do that, we have a very strong governance in place that comprises of the county council, the compliance, the privacy office, the technology, and the provider and administrative leadership. The way we undertake AI projects is to go through this funnel as it shows on this slide. We make sure that every time Epic or any other vendor presents a solution, we have to ensure that it aligns with our strategic roadmap that we have developed, working with the hospital leadership. And it has some measured ROI, not the AI for the sake of AI, but it definitely addresses the bottom line. And we also work with the privacy and security team to make sure that it meets our privacy and security standards. And we also have a generative AI governance committee, which is separate than the AI process that I'm talking about right now. So if any of the solution components comprises of the generative AI, we ensure that generative AI governance committee, or GARC as we call them, has a view of that and make sure that the solution remains compliant. Once the AI solutions go through this entire process, we take on to the pilot. And based on the results from the pilot, we go to scale. Next slide, please, and I'll explain what I mean by scale. This is an implementation methodology. The previous slide talked about the governance for the AI-enabled functions. Here we are saying that how we do that. Once the governance is approved and we have implemented and we conducted the pilot, at the pilot we collect the data, and based on the data, we complete the evaluations that did it really contributed to the provider efficiency, saved time, contributed potentially to the revenue. And if there were some corrections to be made, whether to workflow or the technology, we go through the refined process, which will be different for every different solution. And once all of these requirements are met, then we go to scale. So maybe we started with 50 providers, and if all of these criteria are met, then we will go to the scale, which means that a larger population of the care providers can use it. Next slide, please. We bring one example here of the ambient AI pilot that we just conducted with 50 doctors. Ambient AI is where care providers actually speak to the patients. This software runs on the mobile devices, captures the sound and translates into the text, and eventually updates into the EMR. So all the time that is needed by the providers to type in the notes, that is reduced. Recently, like a week ago, we completed the pilot with the first 50 providers, and the results are promising. That what we have noted here on this slide, that per note, doctors are saving up to 20 to 30 seconds, which doesn't seem much, but when you calculate over the entire day, it's a significant time. This solution is also contributing to reducing the so-called pajama time. That's a time that providers should be spending with their families, but they rather spend that on typing into the EMR. So the initial results based on the 50 providers have been promising, and currently we are still analyzing the results, And as I was showing that process, that once the governance committee agrees that this truly is valuable, we will going to scale it to a larger population of the providers. Here, Vinod, you would like to speak to this one?
So this is a machine. Good afternoon.
Try again.
Good afternoon, Vinod Sharma. This is a machine learning technology. What it does is it looks at all the denials, and for each denial, it looks at the probability of collecting. So allows us to focus on those denials where the probability of collection is very high. And in 1 quarter, it has basically increased our efficiency or collectability by 5%. And the goal is, as we implement more and more of it and we have more experience with it, the gap between what was denied and what was actually received reduces to almost negligible. So in the sense that we collect almost all the denials that were initially made. So in a way, it looks at the probabilities and allows us to do what we can in terms of collecting. So it's working well for the time.
Next slide, please. This slide shows the AI roadmap, what we have on a path to implement. As I was mentioning earlier about ambient AI, that pilot was just concluded, so we will evaluate it and refine where needed and scale it. But in parallel, there are multiple projects that are currently in the test phase. If you look at this slide, some of the text is in the bold, and those are the modules or functionalities or AI-enabled products that are currently in the testing. The remaining are on the roadmap that will be eventually come through the testing. And the process, as I defined, once we test them, they go through the pilot and then evaluate, the refine, and scale. So each one of these will be going through the same process and under the governance that we talked about. So the compliance, the privacy, the security, every component has an overview of these products before they get introduced into the production. That's all I had to cover, and I'm open to any questions, please.
Yes, Paul, you have anything to add?
So what we were hoping to do is first talk about AI and take questions before we get to the revenue cycle.
Sure.
If you have any questions, we'd be happy to respond to them.
Sure. Supervisor Bicola, you have any question about AI?
Yes, thank you. My question, or it's, I guess, comments and questions, really very much appreciate President Lee for asking for or this referral to have more information on AI related to the healthcare system. And I think what's being done is impressive and going in the right direction. I think just in general, and I brought it up at our study session last month, is that the board has not discussed an AI policy, and I know there's work being done at the administrative level, but in addition to things like revenue cycle enhancements and the reasons for engaging with AI, the one area that I think that we often hear most about is like, how does this affect our workforce? And so that's the area that I think we need to discuss and come up with some policy on. So just in general, that is my concern around AI, and that I think we just need to have more conversation about it at the board level and come up with a policy from the board. But I did have questions, and it sort of ties to that regarding how administration has been working with our staff, and what kind of feedback or engagement have you had with staff on the implementation of AI?
Thank you, Supervisor. Just to comment on your first thoughts relative to policies. So what I can share with you, although there may not be an overall county-wide AI policy or general policy, all aspects of the adoption of any tools follow the county process in approvals relative to protection of patient information, patient privacy, the management of data in a manner that does not present further risk to the county or to those involved in its use. So the team, in terms of that governance, spends a lot of time to ensure that we're following and appropriately managing the information that is used through AI technology. And I'm sure the county executive office and others will be working at the board's request to develop a countywide policy. With respect to the users of AI and the adoption of that technology, we work very closely with those that are impacted. So staff, including physicians, as well as in finance, the finance team, to ensure that the technology addresses the core principles in terms of the adoption of artificial intelligence. Not only in terms of return on investment in terms of dollars, but in terms of, as you point out, the way it impacts staff in terms of making sure that it's addressing opportunities for improved efficiency, in terms of their workflows. Technology should be used to augment and support the workflows within any work environment, particularly in healthcare. And I think most people appreciate the fact, as time has gone on with the adoption of technology, we are at the point in which the adoption of AI can reverse some of the workload burdens that the original implementations created. A perfect example is we have a large amount of workload placed upon our physicians in their mailboxes, because people that utilize physician support services in terms of trying to connect with their physicians want to communicate directly with the physicians. And the question is, how do we more efficiently manage their time so that they're actually providing the clinical care that they need? And so the adoption of ambient and other technologies will help us move in that direction.
Great. Yes, and certainly that's, I think it's just that the intent should be to augment, supplement, enhance, make more efficient the jobs that are being done. And I'll just say it, like, I just want to be clear that, and this is what I think we need is, or at least discussion about it, is to say that we're not, the intent is not to replace humans, but to simply enhance the work of our human employees, the staff. So that's what I was trying to, I guess, get to, is that I just want to be very clear, what the intent is. And I think in times like right now, when we are looking at ways to reduce the budget, certainly technology is the way to, help us do that. But longer term, I think we just need to have a policy statement that says that we want to, of course, preserve the human aspect of the work that we do and the services we provide. So, and so then, in terms of quality control, how are we determining whether the tools are at least maintaining current service levels and qualities of those services?
Kala, did you want to go first?
Thank you, Supervisor Abikoga, for the question. I'll briefly address the previous one. I should have clearly stated that in AI industry, there's this term human in the loop. It means that AI is assisting, not taking over. All of the workflows that we are implementing in the hospital, human is always in the loop. Human is in charge. And that also addresses your second question, that how we make sure the quality is there, because we are not letting AI run amok on its own. There's always human involved. And every time we implement AI, we carefully look at the data that is generated. And it is sampled against the benchmarks that we have. We've been using EMR for 12 years, so we have data that how the data is captured and stored and processed. So that's where I was talking about the 4-step process that we do: pilot, evaluate, refine, and scale. Evaluate is the area of that process where we make sure that quality is met or exceeded than humans.
Great, thank you. And then what is the timeline, general timeline of implementation of these AI initiatives?
Yeah, it varies from initiative to initiative. I'll just give a quick example of the ambient AI. The longest time takes is in procurement. Once the procurement is done, then depending upon the complexity of the software, the implementation cycle will begin. In ambient, we can conduct a pilot, say, into 4 to 6 months. That'll be the pilot time. Once the pilot is done, scaling is rather easier. There is not a steep curve in training individuals. Essentially, you need to know how to talk into that and what steps you have to take towards the end just to make sure that what you spoke into the machine is actually properly transcribed to some extent.
Okay.
So there is no one timeline that fits. Some of the workflows are easy to implement and the timeline is really shorter. In others, it takes longer to implement.
And then that you actually touched on that last question I have, and I think really important is the training of staff on how to use all these technologies and ensuring that they have proper training and probably continuous training, because as technologies change, we have to keep up with that. So I'm assuming that is that a part of the your implementation?
Definitely, yeah. That's part of the implementation process. Depending upon the complexity of the tool that is being used, training is provided accordingly.
Okay. And do you do like staff surveys, to make sure that the training is adequate or sufficient for staff to be able to feel comfortable using those technologies?
I believe that is more interactive, like asking the questions. I'm personally not aware of the survey. We'll take the question offline and provide you the information on that.
That's fine. Great. Thank you.
And Supervisor, I would just add in terms of surveying the staff, ambient AI, for example, is something that our physicians are looking forward to. They've made it clear that they would like to implement it sooner than later, but obviously we have to go through the pilot process to ensure the quality control and the appropriate implementation of that technology.
Great.
But we do get feedback from staff in terms of its usefulness and effectiveness.
Good. Great. Thank you. Thank you, President.
Thank you. Yeah, so having many friends in the medical field, whether it's doctors or nurse practitioner, one of the biggest complaint I've been hearing from practitioner is the admin red tape that they will have to do. They love doing the work. They love, seeing the patients and spending more time with the patients. But due to those mundane, I would say the more mundane part of the work, the admin red tape, that they have to fill out the forms and write those things. And it sounded like the transcription process of ambient AI is attacking a good chunk of that work. Am I correct?
The ambient part only addresses one part, which is where the note needs to be typed into the EMR and any actions associated with that. So the work that was generally done by typing into the system, that is being spoken into the cell phone device that gets transcribed.
Right. So, and so far with the pilot of the 50 lucky experimenters, I would imagine the feedback has been extremely positive.
Extremely positive, yes.
Okay, so if anything, I would say is whatever we can do to speed up process, because we have literally hundreds, if not thousands of folks out there waiting for this to be implemented. So I'll say, I understand we have to go through the process appropriately, not to shortcut the short change. But if it's that positive, it seems like this is a win-win. The number, sometimes I don't think really shows how big a deal this is. When you talk about 20 to 30 minutes a day, right? If you add that up plus another 10 to 20 minutes per day after hours, and this, like you say, pajama hours, these are very important time that people can have for the quality of life. And it's a daily thing, right? Number one. Number two is you multiply that by how many people that will be benefiting from this. And finally, I was going to say is this amount of time is not the most enjoyable time for any practitioner. This is not what they really want spending the time doing. So it's not only saving them time, but at the same time doing something that's mundane and not that frankly exciting, I think is where I see this AI, ambient AI, could be extremely helpful. And clearly, it would improve efficiency and also the quality of the provider. So, I'm really ecstatic, very happy to hear about this development. So hopefully we have more of these type of measures that we could pilot out, and that's exactly what I'm looking for. The other thing you talk about is the denial appeal letters, like trying to get the denial letters drafted. Again, trying to draft those letters is like a admin red tape that you don't really want to have to do it, but you really should do it, right? So if this could be made through with AI's help to make those letters drafted much quicker, we probably will be able to draft more of these appeal letters. We'll be filing more of those, and by having more letters being drafted, I would imagine our recovery will be better in terms of revenue. Is that a good way of putting it?
Yeah.
Yeah. Okay. So yeah, I'm ecstatic. I'm very happy to see that these are some of the measures that we're doing, but certainly if there are more opportunities, let's do it. Thank you.
Thank you, Supervisor Lee.
Yep, that's all I have on AI. Okay. Yes, go ahead, Paul.
Thank you, Chair Lee. So I want to turn this over to Vinod to go through some of the revenue cycle improvements that we've seen as a healthcare system.
Good afternoon, Supervisors. Vinod Sharma, Health and Hospital System. The first slide we show is the total posted charges for the last 13 months. The first 3 months were before we acquired RMC. The average was about $700 million a month. And you can see post-RMC acquisition, our average is close to $900 million a month. That shows significant improvement in terms of billing. And if you go to the next slide, that shows the same thing on an average daily billing as to what we are doing. And from $23 million a day to about $31 million a day. That's the net billing increase over the years, over the months. Can you go to the next slide? So this slide here shows our billing history going back to 2018. We used to be $345 million a month. In 2019, we acquired Verity, and 2020, it was $462 million. Last year, before the acquisition of RMC, it was about $680 million, and then it went up to $893, and then last month, we just reached the $1 billion mark for the first time, and hope that we stay in that category as a $1 billion club for months to come. Here, I want to share something else. The efforts with the Revenue Guardian and Revenue Accountability Tool, which is an EPIC tool that allows us to identify missing charges or under collections or under billings, and then coding gaps. As a result, in the last, since 2024, June, when we implemented it, our facility charges or HP charges have increased 37% per month. And the average for the professional billing has increased by 33%. This is also a combination of effort we did in terms of CDI training, the clinical documentation improvement training that's provided to the physicians, as well as the coding training providing to physicians, as well as to the coders. That is helping. And recently, we have established a denial management unit, which basically is going to be aggressively looking at all the denials and seek opportunities to convert them to cash. And that's where one of the tools that Kali that's shown about the AI would also help. So let's go to the next slide. The next couple of slides basically show our monthly collections. And on an average, in 2018, we were collecting $60 million a month. And now we are close to $160 million a month collections. That's about $1.6 billion of cash collections from the revenue cycle in a year. I think, do you have any questions for revenue cycle? Well, thank you.
Thank you, Supervisor Lee. So at this point in time, we're happy to take questions, but just a general comment, and I've said this earlier in my remarks, which is, as a healthcare system, we have the ability to generate revenue, and we do that in a number of different ways. One is, of course, through our revenue cycle process and those improvements, but also through operational efficiencies. So as you well know, part of our initiatives presented to the board for consideration for the current year, but also which will be coming forward in fiscal year 26-27, is really focused on throughput. In other words, our ability to see more patients, whether it's in the inpatient setting, outpatient setting, regarding primary care and specialty services, ancillary services around diagnostic imaging, laboratory, other studies, if you will, surgical procedures, whether it's inpatient or outpatient. All of those, if we're able to show some marginal improvement in terms of efficiency under the current cost structure, then our revenue picture looks better. So you can have a 2 to 3% improvement in our operational efficiency, and it can generate tens of millions, if not hundreds of millions of dollars. So that is an area that we are heavily focused on. I do have to commend the staff who have actually stepped forward and offered solutions around how we can be much more efficient in the delivery of care. So I wanted to share that with you relative to our focus on revenue improvements as opposed to cost cutting. The other thing that I would mention to you, and you've heard a lot about this, is our ability to restructure service lines now that we're a 4-hospital system. At the last, during the study session, we talked about cardiac care and not having multiple very highly skilled and high-cost services at each of the 4 hospitals, but rather folks at one facility will allow us to not only ensure quality and patient outcomes, but also to ensure that we're providing the most cost-effective care where it can be really expensive to maintain. We are looking at a number of other different service lines, whether it be orthopedics, women's health care, et cetera, as we go forward into the coming years. And I wanted to once again reiterate the fact that none of this can be accomplished unless we have the engagement and the support of the staff on the front lines, including the physicians. And they have wholeheartedly, accepted this challenge. And in a very short period of time, I think we've seen some remarkable success in our system relative to improving access, but also improving our bottom line around efficiency. So with those remarks, I'm happy to take any questions as well as those that are present here.
Sure. Let's see if we could have any public would like to speak on this item.
Giving it 1 second on Zoom.
Jess, I think there's some cards behind you.
Oh. These are not for this item, so confirming no request to speak on item 4.
Okay. All right. That will close the public queue on item 4. Vice Chair, do you have any questions on this?
No, actually, just to thanks to all of you. I very much appreciate the revenue generation strategy more than the cost cutting. So we have to do both, but definitely, I think, as you've said, there's opportunity for revenue generation, the consolidation efficiencies. I think we're moving in the right direction and very much appreciate the hard work. I know this is quite a Herculean effort, and so I just really appreciate the hard work that's being done here. So thank you. Look forward to continuing to see the progress.
Motion?
Yes, I'll make a motion to receive the report.
I'll
Thank
go
you.
and second that. I do have a couple of remaining questions. So, Paul, we've heard you mention the importance of growing our primary care, and if you could explain to everyone why this primary care is such an important thing to work on.
I'd be happy to talk about the importance of primary care. As we all know, primary care is really the front door to health care. It's the way in which an individual is actually able to navigate the complexities of healthcare in terms of individual needs. Our ability to grow primary care is critical to the system because it is focused on prevention and really around maintaining individuals' health and well-being. As we all know, that if you're able to diagnose early and care for and treat an individual, then it's much better for the individual's overall health and well-being, but also from a financial perspective, it's much more cost-effective. And so as a public healthcare system, given the fact that we fully expect the number of individuals that are going to fall off coverage, in other words, as you well know, HR 1 really targets those that are on Medicaid, and that represents close to 50% of our patient population. So our interest is to ensure that those individuals, irrespective of coverage, maintain access to primary care for the reasons that I've stated. So that is a big focus of our healthcare system. I would add, and we have representatives from the Community Health Partnership Clinics, which also represents a large number of federally qualified health centers for which your public healthcare system is a party to. The ability for us to continue to provide access collectively, and not just as a county system, but as partners with many of the community providers is really critical, given the number of people that we fully expect to become dependent on safety net healthcare systems. And let me just say this, one of the things that people need to appreciate about our county healthcare system is that it's an integrated system. It focuses on primary care, which is preventive healthcare, all the way through the full continuum of care, to specialty care, to hospital inpatient services, to emergency room care, all the way through to the ability for us to appropriately discharge and place individuals in the appropriate levels of care in terms of subacute, et cetera. That full continuum of care allows us to become much more efficient in the overall delivery of a person's care. And that is part of the reason why we as a public system is somewhat unique. Because of that integrated system, we're able to take risk. In other words, what we do as a healthcare system is not only bill fee-for-service and collect from third-party payers, but we're also able to take risk where we take capitation to manage a segment of our population. So the more effective we are in managing the health care of those individuals, the more cost-effective that care is to our community. So it's really important that we start with primary care, but it's the beginning of the full continuum of care that we offer as an integrated healthcare system.
Thank you, Paul. And that leads to the issue of PCAP, right, which is a primary care access program. I believe this will be coming back to us sometime in the fall on these issues. Anything you want to share with us what you're thinking about in terms of the changes for PCAP?
Thank you, Supervisor Lee. So I think as most people realize, and as I just mentioned, there is a significant portion of our patient population that potentially will lose coverage under the implementation of HR 1. One segment of the community includes the unsatisfactory immigration status, the undocumented, of which we estimate there are around 75,000 individuals in our community that will potentially lose coverage. And as I point out, it's really, really important that those individuals maintain access to primary care, but health care in general to maintain their health. And so we have PCAP, which stands for Primary Care Access Program, for which we are fully committed to, but we're going to have to revise that program to complement the changes related to HR 1. So what we do not want to do is disincentivize people to enroll into Medi-Cal, but we also want them to maintain their coverage. So we have to create a program that is complementary to all the other government options that an individual may have. And I will add that it's just not the UIS population that potentially is at risk here. There are many individuals that in our community, and we know this given covered California, for example, where we've already seen a 25% plus 30% decrease in enrollment in Covered California because of the tax credits are no longer there. And the cost of that in some situations will exceed, in terms of premiums, close to 50, 60%, in some situations over 100% in terms of their monthly premiums. And so those individuals will have to have access to health care in order to maintain their health. And so we're going to have to create a program that takes into consideration all the impacts of H.R. 1 and changes in the federal government in terms of enrollment in some type of coverage program. So we are looking to come back to the
Yes.
board sometimes later this year with a program that complements the needs of this community.
Right, and I hope that when these changes comes to us, you would have had the ability to work with our community partners, like you mentioned, the Community Health Partnership, to come up these changes to the PCAP program. Yeah.
Yes,
That
we will
for sure.
engage with our partners.
Good. As you mentioned, the Medi-Cal type enrollment, we know is going to drop given the changes of HR 1. What would be the best way for us to shed this light so that we could be able to have the data carefully so that we could actually publicize this to let people know how HR 1 is truly negatively affecting our programs in Medi-Cal and how this is hurting our community?
So Supervisor, I think to your point, data and information is really important. And what we will do is in our subsequent reports to this committee, provide updates in terms of the Medi-Cal enrollment in the county. So we'll work with the Social Services Agency and others to make sure you get regular reports in terms of where that enrollment is and how things are projected out going forward. The other important aspect that we've all talked about is to ensure that individuals remain enrolled in coverage in Medi-Cal, and also to ensure that those that are eligible actually apply for and get enrolled. I know there's some efforts underway. I know Family Health Plan and the Medi-Cal managed care plans are looking at strategies and supporting community organizations to ensure that individuals stay enrolled. But to your point, we do have to take it to the next level, and we will probably convene a group that will include the Social Services Agency, healthcare providers, the Community Health Partnership clinics, and others to make sure that we have a very robust and strong strategy going forward.
Great. We talked about revenues today. We talked about how to make something more efficient like AI. We also talked about the future changes to PCAP, how we can make it adjust to HR 1. And the last thing, of course, is with our employees as well, that many people are very concerned or fearful of this future that might be uncertain for job security and whatnot. I just want to make sure that obviously under your leadership, you continue the engagement of our staff to make sure that any type of cuts or decisions being made are being fully informed so that we are working together to make these things as less painful as possible. At the same time, as not lose level of service provided to our customers moving forward, correct?
Yes, we will definitely, as we go through these processes, we do learn, and we have to adjust to make sure that the staff feel supported, that our labor partners feel that they've been engaged with.
Great.
So yes.
Okay, thank you. I've got a motion, I've got a second. Let's go take a vote, Jess.
Vice Chairperson Abe-Koga. Chairperson Lee.
Aye as well, thank you.
Thank you.
Thank you very much. Moving on, we have a report from SCVH relating to status of Hazel Hawkins Memorial Hospital and potential impacts. Go ahead, Paul.
Thank you, Supervisor Lee. So you had requested that we report back on the impact should Hazel Hawkins in San Benito County face struggles relative to maintaining operations. So for most people that do not know, Hazel Hawkins is a 25-bed critical access hospital in Hollister. It typically has an average daily census of around 23 at any given time. And they have an emergency department that sees about 25,000 patients annually, or 70 patients per day. Obviously, we're following that very closely because the closest facility to Hazel Hawkins is St. Louis Regional Hospital. You know, we've done some estimates to get a sense of what the impact should be should something happen to Hazel Hawkins. You know, we estimate that, as provided in the report, that, you know, we could very well see close to 40% increase in patient volumes at St. Louis Regional Hospital, which could represent anywhere from 40 to 50 patients a day. Some of those patients, depending on their acuity, may not come to the emergency room. They more than likely would access available urgent care centers, for which we do have urgent care centers in both Gilroy and Morgan Hill. But the short of it is that just like in any community, when you have a loss of a major service provider, there's a downstream of impact for which we are looking to address should that come about. So I'm happy to take any questions.
Sure, thank you, Paul. Let me go to public. Anybody in public like to speak on this item?
Confirming no request to speak on item 5.
Okay, thank you, Jess. I do understand that the Insight Health had withdrawn from negotiations on this proposed lease to purchase agreement for Hazel Hawkins, right? And is that our understanding at this point? How likely, unlikely, you think Hazel Hawkins would even stay open for another few years?
Supervisor, it's really hard to say at this point in time. I do know that they are looking for a new partner in order to have the financial support to maintain the facility in that community. So what I would say is that any hospital of that size, it's very hard to cover your fixed costs, right? So if you're a critical access hospital, you do get some benefit in being one of a few hospitals that receive that designation. But if the volume is low and your costs continue to grow, it's very hard to maintain your revenue, to maintain operations. I would just share with you, Supervisor and Supervisor Abakoge, that you all know that the other hospital, rural hospital that's out there is Watsonville Community Hospital. And in last, I think earlier this year, they announced that in 2025 that they had a close to a $22 million budget shortfall deficit. This is Watsonville. They are also looking for a financial partner, a community partner, if you will, a healthcare partner to maintain operations. There were rumors earlier in the year that their ICU may be impacted because of their inability to staff their ICU and the cost associated with that. So you can see that these hospitals are struggling, and it's further complicated by H.R. 1 because those hospitals see a large percentage of Medicaid patients or Medi-Cal patients. So when you have a large percentage of government-sponsored patients, you are going to have further problems in terms of maintaining operations.
And on that note, Paul, we need to clearly increase the ED capacity at St. Louis, given these challenges that we are anticipating with Hazel Hawkins' situation. Could you share with us, I think we talked about these medical mobile units that you're working on. You want to share that with everybody on this one?
Thank you, Supervisor. So most people know that when we acquired St. Louis Regional Hospital, the volumes were probably around 100, 110 ED visits per day. That volume on some days exceed 150, 160 patients per day. On average right now, it's around 130, 20 to 30 patients per day. They have 8 currently licensed ED beds. For volume in that amount, it is insufficient. We did open some temporary facilities for which we are trying to get further waiver on through the construction and actually implementation of a mobile medical modular unit outside of the ED, which represents another 8 beds to deal with lower acuity patients. On top of that, we are actually looking at a second modular unit now in preparation for the ongoing demand and potentially increase of probably another 16 beds. So in total, 24 additional beds that would be able to support St. Louis Regional Hospital. I would simply say that this is an interim measure because obviously longer term, we do have to build out a longer term facility to care for that community in the South County. These volumes are going to continue to grow on us.
So on the timeline, when do you think these mobile units will be in place?
These, I would rather call them modular units, and those modular units, the first 8 are supposed to be in place by March, April timeframe was the schedule.
Okay.
And then next year sometimes will be the additional bed capacity. While we do have a white structure out there that is only temporary, and we have to get the waiver in order to maintain that capacity through the modulars.
Okay. Thank you, Paul. Yep. Yes, you have a
Question
Sure.
on
Go ahead,
it.
please.
Is there some kind of timeline or how long the modulars are considered good for? Or,
So depending on the circumstances, Supervisor, we go in 12 months increments, so we have to get a waiver from
Every 12
DHCS. And they've been given approval on 12 months increments.
oh, okay. So
And
it's
that's
not,
obviously to make sure that we're maintaining the facilities in a safe manner.
okay. So it's not I was thinking years, like 5 years, 10 years, but it's
Well,
more yearly.
Such facilities could be in
Wow.
place for up to 4 to 5 years
Okay, okay,
if they're maintained and
Uh-huh.
we continue to get approval from the state.
okay. Thank you.
Thank you. I know we are talking about a kind of a hypothetical worst-case scenario for Hazel Hawkins, but at the same time, I think we need to be prepared for the worst-case scenario. So I just want to thank you and your leadership and your team for getting that ready for St. Louis. So I just want to say thank you very much for that. I did have one speaker card. I normally don't call people back because we close it, but in this case, I'll go ahead and do it because I just quickly, 1 minute, because of the fact that next time, if you need to get a speaker card, make sure you get in early. Okay, go ahead. 1 minute.
My apologies, I wasn't going to speak on it, but I thought it's important as someone who lives in Hollister, works for the county, just so you know, and I'm one person, but I do have a lot of coworkers who live in Hollister. As you know, we've had an influx of people who have moved in, and it has created an impact of services. We go to Gilroy, just really quick, with our insurance, you're limited, and so I have Health Net. And so some of my providers that I've had over the years get switched around often because of all kinds of reasons. So stability of our medical provider is not consistent for me and my family, so we do frequent St. Louis and Hazel Hawkins. And so I just, I can't emphasize enough the importance of both of those facilities. And if there's any way for us to continue that support, I felt compelled to say that. Thank you.
Thank you. All right. Do you have a motion to receive the report?
Yes, I'm happy to make the motion to receive the report.
I'll go ahead and second that. Let's go take the vote, Jess.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. Moving to item number 6, which is considering recommendations relating to the Cove program. I believe, who is here?
Yes, good afternoon.
Oh, Dr.
Supervisor
Yes,
Lee.
you're up here. Sorry.
No problem,
I didn't
and we
see
do
you.
have our staff here as well.
Hi, good afternoon.
So good afternoon, Supervisor Lee, Supervisor Abekoga. You have our most recent report on Cove. This follows our presentation back in December where we were asked to follow up, provide some additional meetings and engagement with community partners around Cove, which we were very pleased to be able to do. And we are, continuing to be committed to providing services, mental health services for youth in North County. So we have our report. We have Megan Wheelahan, our Deputy Director, and Jennifer Pham, our Division Director here as well.
Okay, thank you. Yes, good afternoon.
Good afternoon. Happy to answer any questions you
Sure.
may have about the report.
Thank you. I guess I will go ahead and open up the public to let the public speak first. How many speaker cards do we have, Jess?
We are currently at 12 and climbing. I will do a last call on Zoom. If you're attending on Zoom and would like to speak on item number 6 regarding All Cove, now's the time to raise your hand. We seem to be holding at 6 for a total of 12.
Okay, let's do 1 minute each, please.
Okay.
In person first. Thank you.
So we'll close the queue at 12 speakers and call up our in-person cards first. We'll start with Carla Torres, Julie Lithcott-Hames, Elizabeth Fitton, and Ana Lilia Soto. And you'll have 1 minute
Thank you.
to speak.
Yes.
Please go ahead.
Hello, my name is Carla Torres, and I'm here as a community advocate representing the NAACP. We're here advocating to ensure continued funding of essential professional services by Cove. And we know you have budget constraints, but these decisions must be balanced with essential services to our community. As you know, the board is aware of disparities that exist in our community, and including the recent report on child deaths that showed our most vulnerable and oppressed communities that include our child and youth. And the regional services, specifically in North County, are so needed in light of the suicides in those reports. And so we recommend approval of the proposal and being presented so that there's continued funding for Cove and a plan for sustainability, especially for the needs of Palo Alto community. Thank you.
Thank you. Go ahead, Julie. Yes.
Thank you, Supervisors. I'm Julie Lithcott-Hames. I proudly serve on the Palo Alto City Council. Thank you so much for your support of youth mental health in the county and in our city. As I know you have been made aware, in between our last meeting and today, we've lost another youth at the train tracks at Churchill. And so this is an urgent crisis in Palo Alto, yet again. All the more reason to ensure that all Cove funding is preserved. I want you to know that the city is doing its part. Immediately, the mayor reconstituted an ad hoc called the Rail Safety Ad hoc that I am chair of, and I serve on it along with Councilmember Burt and Councilmember Vice Mayor Stone. So we're addressing means restriction and how to make that area of our city more safe. Looking at hiring crossing guards to be there 24/7 and potentially closing the road that intersects with the trains. Thank you.
Thank you. Yes, go ahead.
Hi, my name is Ellie Fitton. I was one of the first youth advisors for the launch of All Cove Palo Alto. Helping to build these centers has been one of the most important things I've ever been a part of, and it's been so meaningful to see the centers now open because I know how much thought and care has been put into them and continues to be put into them. I was a student at Palo Alto High School during the aftermath of a suicide cluster at Pally & Gun. I knew many kids who were struggling. However, I had one close friend who I didn't know was struggling, not until I got a late-night phone call one night where she tearfully confessed she was experiencing suicidal ideation for months. I tried my best to say the right things, but I was scared and ill-equipped to help her. She said she wanted to get help, but too much was on her plate at the moment. She was taking the most APs out of anyone I knew, and it stressed her out to go through the logistics of finding a therapist, especially since her parents didn't believe in therapy, and seeing the school counselor during the school day felt too overwhelming. She continued to struggle for a long time. When I became involved with All Cove, I heard similar stories from my fellow youth advisors who are hospitalized.
I'm sorry, we next time, what you could do is please give our full complete statement that you prepared. Please go and send it to our clerk. We'll make sure we add it to the record. I'm sorry to cut you off early. Thank you.
After Ana Lilia, we'll hear from David Mineta and Pat Burt.
Hi, everyone. Ana Lilia Soto here. I come to this chamber as a community member really appreciative of the commitment that this county has had with regards to youth mental health and fully support the continued financial support for All Cove Palo Alto. I understand what the lack of services does to a community in need. I've had the honor of working with young people, families in this community for the last 25 years, from gang intervention to supporting young moms to youth directly involved with our juvenile and foster care systems. In 2017, I came to Stanford to support the creation of Cove as an integrated mental health center centered on youth with the development, from the development to the implementation of services. Our youth then and now ask for a creation of safe and brave spaces, working with our youth to develop a model that focused their needs in the center and created accessible pathways. And this is a community that's in dire need of community healing. In Palo Alto alone, you've had 8 cohorts with about 200 total youth that have invested time and energy for their center. The goal is really to reduce stigma and to reduce barriers to care. Thank you very much.
Thank you.
Good afternoon, Chairman Lee, Vice Chair Abe-Koga, County Administration. Thank you for the opportunity to discuss the fate of Cove Palo Alto at this most critical time. Last November, the recommendation to close Cove was born from the dire financial emergency facing the county, this region, and state. The discussion that ensued was in response to a current public health crisis, specific to the area, but also connected to the emergency that President Lee and Supervisor Ellenberg declared in 2022. I was proud to stand by you then, and am proud to stand by Supervisors Lee and Abe-Koga today to keep the doors of Cove Palo Alto open and serving the community during this very specific public health crisis. There is an understanding in principle before the budget process begins that Alum Rock would take over as the lead agency with county-based support of $1.75 million a year for 3 years with partners agencies identified. We will do whatever we can to lead this community effort to meet this moment. Thank you.
Good afternoon, supervisors and staff. I want to thank you all for the effort that you have made in working with us to present this program that you have going forward. I want to share that the $1.75 million that we tentatively are looking forward to, we are treating as a foundation in our community, and we have already assembled a plan and a group of a team to develop the funding sources and in-kind services to supplement that foundation. And our goal is to raise a combination of $1 million a year and hopefully more. We're on a scramble because we need to come forward with that within the coming just few months. But the city of Palo Alto is, despite their own severe budget crisis, is committed to being a seed and founding funder. We're looking at other partners throughout the community to contribute as well. Thank you.
Thank you.
We'll move to our Zoom speakers. Our first speaker is Carrie Wagner. We'll open your microphone. And you'll have 1 minute to speak. The timer will start when you begin speaking.
Hi, my name's Carrie Wagner, and I'm a Palo Alto resident, and I have 2 children who attended our Palo Alto public schools. I want to thank county staff and supervisors Abe-Koga and Lee for funding Cove, hopefully at the $1.75 million level, and for recommending to the other supervisors that we keep funding at $1.75 million for each of the next 3 years. I hope all of your colleagues on the full board will support this funding. My children went to high school in Palo Alto during the previous 2 suicide clusters. Cove did not exist, and we were desperate for this resource. So please, we really need this for our families. Thank you so much.
Our next speaker is George Liu. George Liu, we'll open your microphone. You'll have 1 minute to speak. Please go ahead.
Supervisors, thank you. I'd like to briefly emphasize previously made points that the city is doing everything we can and how unfortunate the timing would be if we were to withdraw Cove services. In partnership with the school district, we're working with the JED Foundation, a preeminent organization for youth mental health and public health, to audit all of our services and how we deliver mental health care, including All Cove. Councilmember Burke could also speak to the work that we've been exploring with Caltrain about securing our grade crossings. And as Councilmember Lithcott-Haim mentioned, next week the City Council will actually vote for security guards at our Caltrain grade crossings. We are trying to do everything we can. I understand the needs around All Cove program updates, program uptake, and the sustainability of its funding, but I think this budget action is a really great opportunity to improve and reevaluate the program for the future. Thank you.
And our next speaker is Nayeli Gomez. We'll open your microphone. Please go ahead.
Hi, my name is Nayeli Gomez, and thank you to the county staff, and thank you to Supervisors Gabby Koga and Lee. My son is a regular at Alcove, so you might have heard about him. Is Nathan Garrido Gomez. So please help keep this place open. So people are amazing. They are like really caring. We're struggling. Families are struggling here. Our youth is struggling here too. So you have heard like we have another suicide. Kids need a safe place like to be. My son feels like it's literally his second home. So he spent like time like with all the kids there. And I said kids because it's run by our youth too. So it's for them, it's just a space where they can actually like be themselves, and they are supportive, like they do like simple stuff. So go, say it.
Please save Alcove. Can you please save it? We need it.
Thank you.
Our next speaker is Maribel Ramirez. Please go ahead. Maribel Ramirez, you'll have to, there we go. Thank you.
Hi, good afternoon. My name is Maribel Ramirez. I'm a grief peer counselor at Clara, and I work with the Latino community around grief. And I'm also a mom with 2 children here in the Palo Alto School District. And as a mom of a neurodivergent child with general anxiety, I know how essential it is for youth to have stigma-free spaces in our community where they feel safe, understood, and supported. Spaces like Alcove provide caring peer support, trusted adults, access to therapy that is accessible and free, and a welcoming place to simply connect and belong. Those are protective factors that reduce isolation and prevent crisis. I want to thank you, the county staff and supervisors, Abby Conga and Lee. Thank you. Please consider keep this center that we all need, all our families and our youth. Thank you very much.
Our next speaker is Emily. You'll have 1 minute. Please go ahead.
Hi, my name is Emily. I'm a Palo Alto High School alum from the class of 2022, and I am on the board of Project Safety Net. Growing up in PAUSD, I had countless friends struggling with mental health and suicidal ideation. They were often too afraid to go to family and felt that seeking support through school would follow them in ways they couldn't control. So they turned to friends like myself and other teenagers. I was 12 years old the first time I was afraid a friend might take their own life, but it was nowhere near the last time. I'm so grateful to say that these friends are safe today, but feeling like you are responsible for protecting someone's life in an environment where they feel like they have nobody else to turn to is an overwhelming burden for a young person. And that level of anxiety and responsibility should not fall on students, yet I guarantee it does to this day. That is why I believe that Alcove is so important. It provides a true third space separate from home and separate from school, where young people can seek support without fear and judgment, with a level of anonymity that matters. For students facing stigma, whether because of their gender identity, sexual orientation, cultural background, or other circumstances, that kind of space is absolutely critical. Thank you.
And our final speaker is Fund Alcove. You'll have 1 minute.
Hi there, my name is, can you hear me? Yeah. Hi, my name is Ronnie Jayakumar. I'm a parent in Palo Alto. I want to thank the county staff and supervisors, Abby Koga and Lee, as well, for funding Alcove, for supporting that. We in Palo Alto are hurting, and the kids are hurting, the families are hurting around all the recent suicides. And despite our efforts, we feel that Alcove is such an important part of a larger strategy that we all need to help keep our community safe. So I'm really asking you to take this to the full board to also vote in favor of funding Alcove at 1.75 million for the next 3 years. Thank you all for all you are doing, and thanks to our community for everything that they are doing. This is such a critical part, both in our community and in our schools and in our county. Thank you.
And that concludes public comment.
Thank you. Go ahead and close that queue. Supervisor Albicoga, do you have any questions on this one?
Thank you, President Lee. Just first of all, I wanted to thank you for bringing this back and putting it on today's agenda. I want to thank staff and all our community partners and the community for your engagement and involvement in this process. I would be, first of all, remiss if I did not acknowledge the profound tragedy that our community experienced since our last HHC meeting. As mentioned, there was another tragic student tragedy just 2 weeks ago in Palo Alto. And so I've been so heartbroken since the news. This is a personal issue that's very personal to me. And so it's really been on my mind since, and just the feeling that, we need to do more and move more quickly. And so I'm glad that we are here today. I think that we are in a good place to be able to make a strong recommendation to the full Board of Supervisors. And, again, I'm committed to, as decision makers, working together with our community to provide a safe haven and a pathway to hope and flourishing for our young people. And I just, want our young people to hear that message clearly, that, we are here for them. And even in the deepest moments of despair, they're never completely alone. So in that regard, I'm glad that it sounds like our staff has reached agreement with our partners. I think the Ellen Rock Counseling Center and BHSD staff have come to an agreement on some of the key aspects of how to proceed on this issue to be able to maintain Alcove. And frankly speaking, I think that, as some folks said, this was a great opportunity for us to, revisit the program and see how to improve it. And in the long term, I'm very confident that it'll be a stronger program as a result. I very much appreciate the community, the city council members who are here, and to hear that there is interest in getting community involvement and in participating and jointly investing in this program is what I think will make this a stronger program. And I think that's the beauty of our community, is that we are definitely in a challenging time, but we've seen through Measure A and then through this process how the community is willing to come forward and to support and help. And so that's why I'm always very, it's very reassuring in that sense. And I think that to me shows how important it is for us to be outward facing and involve the community whenever we can, because again, I think we are stronger for it when we have more participation from our community with our services and efforts. So with that, if I may, I'd like to make a motion to move forward a recommendation to the full Board of Supervisors to allocate $1.75 million for 3 years with CPI increases built in for years 2 and 3 to be provided to a community-based service organization to deliver behavioral health services to youth in North County. And I do want to emphasize that Alcove is for all of our community, and specifically for North County. Further, I move to forward staff recommendations to the board to have Alum Rock Counseling Center take over the programming from BHSD, serve as the lead agency for Alcove Palo Alto, and take on the trademark agreement with the Behavioral Health Commission. And additionally, Alum Rock is welcome to partner with other organizations such as Pacific Clinics to continue the behavioral health services component for the mild to moderate population.
Yeah, strong second on that. So I first want to say I'm truly happy to see that this opportunity of administration striking this compromise, working with Stanford, Alum Rock Counseling Center, the North County communities together to continue the Alcove services in Palo Alto, or not let that program vanish after all that hard work that we put this thing together for so many years. And starting with the time when the Supervisors Committee was here, that's how when they all started. And I just want to say, Supervisor Pekoga, thank you so much for your office for playing this instrumental role, supporting these tough decisions and discussions, and working toward the solution that works for all parties involved to ultimately support our youth and young adults in need of support. I do have a couple of questions for clarification, if I may. In terms of the cost here, how much would the funding of the facility lease, ARCCs for peer supports, the pro-social workshops, and the education and employment supports cost approximately on an annual basis?
Yes, thanks for the question, Supervisor. We're going to pull up the breakdown between the lease and the contract for the peer support services.
Okay. If you need to take a minute, I could ask the other points, if that's okay.
That'd be great.
Sure. So the report also talks about ARCC will be working or partnering with Pacific Clinics to continue the behavioral health services component for the mild to moderate population. Can you maybe illustrate how do you think this partnership will work out in practice?
I think that will be somewhat for the two organizations to work out together, but what that would potentially look like is staff from Pacific Clinics on site that are able to bill through the school-based initiative fee schedule, so that there is some reimbursement coming in for youth who are either non-Medi-Cal or non-specialty level of mental health services.
Okay. Do you know of any other partnering organization that's also offered this type of support as well besides Pacific Clinics?
Yes, there are other organizations throughout the state that are providing services under the fee schedule. In order to do so, they have to develop MOUs with individual school districts. Pacific Clinics is the organization that is developing those MOUs in the North County right now.
Okay. I did hear that there's a noticeable increase in services at Alcove back in January. Can you share more about what this new development of this increased services is?
Good afternoon, Board of Supervisors.
Justin.
I can provide some clarity on that. The January numbers saw an increase from what was comparable to November and December. However, the numbers are still consistent into what we've been serving throughout other months. And then to go back to your questions in regards to the funding breakdown, the rent cost on an annual basis is roughly about $300,000, a little bit more. And then for the contracting with Alum Rock, it is roughly about 700. Oh, sorry. Our current contract right now is about 700,000.
Okay. Current contract. Okay, thank you. I think that's helpful to understand, and I certainly think that the motion addresses at least the 1.75 million per year level as proposed. And of course, we can approve it. This has to go through the full board just to make sure everybody understands that this is not an actual approval of this, but it's just a recommendation. But I do want to really thank our community partners who spoke today, regarding coming up with other revenues. We are all shaking the money tree everywhere we could find it. And it's not just for Alcove, but as we know for our hospital systems and whatnot, due to these HR1 cuts and whatnot we are facing. So I just want to say thank you for the Palo Alto City Council for stepping up, even though despite these difficult times, I want to do this shout out on that. And any of the partners that you're able to talk to, and I'll be more than supportive, whatever I can do to help you to raise those funds to make sure that Alcove will be successful moving forward. Okay. And with that, we've got a motion, we've a second. No more comments. Let's take a vote.
Vice Chairperson Abe-Koga?
Aye.
Chairperson Lee?
Aye as well. Thank you very much.
Thank you.
All right, 7 has been moved to consent. Let's move to item 8, which is receiving reports from the Public Health Department relating to the harm reduction program. Dr. Redmond.
Thank you, Chairperson Lee, Vice Chair Abe-Koga. I'm pleased to introduce Dr. Kanksha Vaidya. She is our Assistant Health Officer and STI and HIV Controller. She is working to broadcast the slides right now. There we go. So she'll have just a very brief, I think, 5 or 6 slide overview of the program and some of our accomplishments, and then we'll be happy to take any of your questions.
Thank you, Dr. Redmond. So I'm happy to share some highlights from the full reports that you both have with you. To start off with, I wanted to share the overall state of overdoses in Santa Clara County. So if you look at this graph, it's showing the total number of overdose rates, deaths due to overdose in Santa Clara County from the 2000s. What you'll see is that these deaths were increasing quite steadily. But in 2023, we actually started seeing a decrease in the deaths due to overdose. The reasons for this could be multiple. It could be that we're finally having good outreach, and it's because of all these years of work and effort that we have put into this work. But what's really important is that ongoing work for overdose prevention and harm reduction really needs to continue to maintain this downward trajectory that we've started seeing. When it comes to our harm reduction program, we can see that year after year, the number of clients that our program has served have continued to go up. In fact, in fiscal year 25, we actually saw a 40% increase in unduplicated clients served by our program. Because of the increase in clients, the cost to operate the program have also continued to go up. We've also seen that the number of syringes that we've distributed has gone up year after year, and this is because the number of clients we've served has gone up. But what's notable is that if you look at the number of syringes distributed per client, this number has actually started to go down. And this is likely because alternatives to injections are being distributed more and are more in demand. We actually know that smoking or snorting drugs actually carries a lower risk of overdose and also carries a lower risk of certain infections that are specifically associated with injection drug use. We also think that this decline could be because of the start of our low barrier MAT program, which makes sure that those who are ready for treatment have access to treatment whenever they need it. In addition to these supplies, we also distribute overdose prevention supplies. So we distribute naloxone, fentanyl test strips, and recently have started distributing xylazine test strips as well. Year after year, the number of doses of naloxone that we distribute continues to go up. We also ask our participants if they've ever had any overdose reversals. So these are self-reported overdose reversals. And in fiscal year 25, we had 584 self-reported overdose reversals. That's really 584 lives saved. Because of the increasing need for services from our program, we've done a few different things in this past fiscal year. First is that we've increased our outreach to encampments. And what this allows is that for those people who can't come to our program, we go to them to make sure that they have access to these life-saving supplies. We also installed our first harm reduction vending machine at our public health department. Along with stocking naloxone and fentanyl test strips for anyone who needs it, this vending machine also has syringes and alternatives to injection supplies for our program clients. This allows clients to access these life-saving supplies even during hours when our program is not operational. We also continue to maintain our website, OD Free SCC, which is a centralized hub for any resources related to overdose in the county, including data around overdoses. And we've been updating the website based on feedback from the Drug User Health Advisory Committee and the OD Free SCC Coalition. Lastly, in fiscal year 25, we worked closely with the Behavioral Health Department to initiate a strategic transfer of the naloxone distribution program from behavioral health to public health. Working closely with behavioral health will really allow us to continue the important work of ensuring that naloxone is available throughout the county. So looking forward to fiscal year 26, we are looking forward to assuming leadership of the naloxone distribution program. We're working on creating a data-driven approach to naloxone distribution. So we've been working with EMS to get data on overdoses throughout the county, and we'll be focusing on overdose hotspots to make sure that naloxone is available there. We're also collaborating with different county organizations and partner organizations in the community. One novel partnership we're exploring is with BART to ensure that there are more naloxone boxes available throughout the county. We're also collaborating with key clinical partners in SCVH to expand the reach of overdose prevention supplies and safer use supplies through these clinical partnerships. So overall, even though we are seeing this encouraging trend of reduced overdose deaths, the environment in which we're working is actually getting more and more challenging. Some of the things we've noticed are that there are increasing encampment abatements that have been happening in the past couple of years. Whenever encampments are abated, this creates displacement of clients and makes coordinated care and continuity of care difficult for our clients. Also, because of changes at the federal level, there is increased stigma for the population that we serve. And then there's also threats to federal funding that could further hamper the services we provide. So really looking forward to the next fiscal year, our job is to maintain the services that we currently provide, meet the needs of our clients, and to do so in an increasingly challenging environment. Thank you, and I'm happy to take any questions.
Thank you very much. Do we have any public who would like to speak on this item?
There are currently no requests to speak.
Okay, close the queue on that. Vice Chair.
Thank you so much for the report. During the last, I think it was the last meeting or 2 meetings ago, I had asked about safer consumption supplies, including needles, pipes, and foil. And I was hoping you could talk a little bit more about some of the data that supports this initiative, and then ways that our public health department is working to dispel misconceptions about safer consumption supplies.
Sure. I'll take a first pass and then see if Dr. Vedya has anything to add. I think that the evidence that supports the idea that syringe access through a program like the one we offer reduces significantly rates of diseases like HIV, hepatitis C, and many of the infections like bloodstream infections, heart valve infections that land folks with prolonged and expensive hospitalizations and life-threatening diseases. There's extensive evidence to show that those really are effective. In fact, one of the things that is reflected more in our Item 7 report showing the HIV rates here in Santa Clara County, we actually have relatively lower levels of HIV among people who use drugs, and a lower proportion of all of the population living with HIV in Santa Clara County had injection drug use as a risk than many places all over the country, including equally well-resourced places like compared to Santa Clara County. So that does show us the evidence that our now 30-year investment in syringe access is paying off in reduction in infectious diseases. What changed several years ago, I think, was 2 things that taught us that we absolutely had to expand beyond just syringe access and related HIV and infectious disease testing. The first was some early evidence that pipe exchange also itself reduced the risk of hepatitis C, coming out of some pilot projects in San Francisco around the time that they were launching their Getting to Zero HIV project. Learning that because we were seeing smoking emerge in certain types and patterns of drug use, there were diseases we could further prevent through pipe access. But especially as you saw in that very first slide, the really striking uptick of overdose deaths we saw around 2015, 16, 17 told us that we needed to be doing something very different to stop people from dying while we work to get them into treatment. And one of the things we recognized is smoking or using means other than injecting of a drug that can cause an overdose death is much less likely to lead to death. That when you inject a drug like heroin, like fentanyl, that can lead to overdose death, that death is much less likely if you're smoking or consuming a different way. So by offering people an alternative to injection, which we also found from our experts in the field was acceptable. Folks said, I may not want to be using drugs at all, but I don't want to be injecting if I have another way to consume while I get treatment. The people were open to transitioning to safer consumption supplies. And then we were also learning that there were a lot of people out there who weren't injecting, but who weren't engaging in any of the other supportive services our harm reduction program was engaging in. And by saying this is also a place where you can talk about your non-injection practices, and we will still offer you HIV testing. We will still offer you an expedited route to treatment. We understood that we could meet that need by expanding into those services. And that's part of why the state of California made all of these supplies available, started recommending this across all California syringe services programs, why it's become a best practice nationally, and why it was originally part of the express recommendations coming from our federal partners as well.
Okay, that's very helpful. Thank you. The reason why I asked is I've heard the concerns about providing these supplies, and does that imply that it's acceptable to use drugs? And so how do we move away from that? And I understand now that this is it seems like the focus is to prevent deaths and other diseases, illnesses. But yes, the issue of, well, how does this actually then affect, and I think this goes to the treatment, and do we have the adequate services to eventually help folks to overcome their addiction?
Right, certainly that idea of making access to treatment integral, open, accessible, easy at every point of care during harm reduction services is something we are consistent about. So that the moment someone is willing to accept support for accessing treatment or for reducing their use and making their use safer in other ways, we're ready to support them, is a consistent part of what we do. But I think what was striking for me as I joined the public health department just about 10 years ago in the role Dr. Vedia is in now, and really had to learn about this world in a different way than I learned in my medical training. I also came with the understanding, wouldn't you imagine that by making the paraphernalia for use more accessible, you would make use easier and therefore more likely to happen. And over again, which surprised me when I first learned it, that is just not what the data show. And that is not what we hear from community members who either have lived through drug use or are living with drug use right now, or have worked with these communities for a long time. There is really no one we ever encounter who said, I had no interest in doing heroin until you offered me that free pipe. Now I'm thinking about it. In fact, what we hear is, I am desperate to use. Thank you for helping me think about treatment. I'm going to use by any means possible right now because my brain chemistry has been so completely rewired. And so whatever you can do to keep me safe, keep me alive until you get me additional treatment is going to be appreciated. And so part of our respect for care for the community members who are using drugs right now is to make sure that they have every single one of those options available to them as the safest way possible.
Great. Well, thank you. I really appreciate that explanation. Thank you.
Yes, thank you so much, Dr. Redman, on that issue regarding the needle exchange program of why we're providing those paraphernalia. It's not an encouragement. I analogize this like to the condom distribution. Same thing. It's like, well, by giving condoms, aren't you encouraging people to have sex? Last thing we consider is basically people are going to do it anyways. And if you use to do these things that we really are trying to discourage you to do, at least you're not also spreading diseases or getting people pregnant and whatnot. So that's why these type of distribution, I think, is important. It's data-driven, but at the same time, there are folks who just have a complete different opinion based on their beliefs or whatnot, and there's not much you can do. One thing I would say that's truly important in this report is the deaths that's been shown in the last few years. 353 to 317 to 275. These are real lives of decreases that we're seeing that are lost in the community. And what's really exciting is that slide that shows a 584. That's reported. Not everybody who was saved from an OD would report this. So 584 is actually the lowest number. We are probably talking about double of the amount of folks' life has been saved, right? So I just want to make sure that's why this work we're doing, distribution of Narcan and all these other measures are so important because we are literally saving lives. Oftentimes we could debate here all day about something, but very few things are truly life and death. And this is absolutely life and death. And I just want to thank you and your team of the amazing work that this county has been doing. Of course, even 275 is still 275 lives too many. But I don't want to overlook the fact that these type of decreases did not happen by accident. Now, the other few questions I want to follow up is the issue of methamphetamine, right? We know fentanyl, that Narcan, works for that drug, but it does not work with meth. And the number of people who are dying from meth is still very significant. Would you want to share with us what type of treatment options we have there and what other recommendations you can provide regarding meth, since there's so many people affected by that?
Do you want to start that and then I'll?
Yeah. Okay. Thank you, Supervisor, for that question. I just wanted to reiterate that it's correct, absolutely. We've seen year after year that overdoses involving methamphetamine are much higher in number, actually, than overdoses involving fentanyl in Santa Clara County. So definitely, we are, working towards looking at overdoses due to methamphetamine and what we can do to combat that. From a harm reduction standpoint, similar strategies that we use for opioids are applicable to methamphetamine use as well, with the exception of Narcan, because that does not work for methamphetamine. Mm-hmm. But things like sterile syringes, increasing alternatives to injection supplies will reduce the risk of infection, at least that is associated with injection drug use. So those are harm reduction strategies that we continue to work on. We are also in the upcoming years hoping to get more insight from our participants about what additional support they need if they are using methamphetamine. What can we do to support them so that they can start on their treatment journey or healing journey wherever they are in their journey? With regards to specific treatment options, I'd actually like to defer to our behavioral health experts since they're the experts in the treatment field. So.
Yes, Dr. Terrell?
Sure, thank you for the question. With respect to treatment of methamphetamine, contingency management is the evidence-based treatment that is highly recommended to treat methamphetamine addiction. And it's essentially providing monetary or motivational incentives for individuals that are showing positive behavioral change as evidenced by negative drug tests. So we do have a couple of our providers in our behavioral health network that do provide contingency management. And I also am aware that this is provided through our Compass Clinic as well. So we are providing that across our network.
Yes, I have an opportunity to visit Compass Clinic about a month ago to see the good work is happening right there. I do want to see if, based on these contingency management, I don't know how you keep track of the numbers, but I certainly would love to see the effectiveness and the quantity of folks that are taking these cash or incentive to taking this the P-test, right, to show that they're not using drugs. And I think that program is certainly extremely important. And I want to make sure that gets advertised in a greater sense. When we distribute these syringes, for example, that certainly is a great opportunity to explain what other programs we have. Those are certainly included in every syringe that we distribute, correct?
Absolutely, Supervisor. So linking people to contingency management and other harm reduction and treatment for methamphetamines and stimulant use is absolutely a priority of the program as well. And I apologize, remiss in not congratulating and thanking our Behavioral Health Services Department. Against all odds, as we've been discussing since the beginning of this meeting, they have managed to grow very many of their services that contribute both to overdose prevention and treatment of substance use disorders. And I think that's a huge reason why we've seen the successes that we have had to date. So thank you for that collaboration. And we're looking forward to continuing to support and be that bridge from finding folks who are currently using, making sure they do so as safely as possible so that we can get them to the services with our behavioral health service department.
Well, we've been talking about budget cuts for a long time, and we have also been talking about the use of the opioid settlement funds. With these type of cuts, has that affected this contingency management in terms of these cash or incentive for people who do not use drugs?
At this time, we're still continuing to provide those services and programs, so at this point, there isn't a budget impact.
Good, yeah. Yes. And if you could actually provide Dr. Rao, if it's possible in the future, just to give us some report on the scale of how many people are enrolled in these programs, whether they're increasing, and these success rates, because obviously the longer the folks are off these type of drugs, are higher chance of success. Is that something that we could get in the future?
Yes, we can provide that
Great.
information,
Right.
Supervisor.
Thank you so much. Okay, and that's all I have.
Thank you so much.
All right, thank you. You have a motion? Yes, please.
To accept the report?
I'll second that. All right, let's go take a vote, Jess.
I can't remember if we called for public comment, but there is no public comment on
I'm
item
sorry.
8. And with that, Vice Chairperson
Thank you.
Abekoga?
Aye.
And Chairperson Lee?
Aye as well, thank you.
Thank you.
Okay, moving to item 9 regarding the Public Health Department on the tobacco retail permit program. And Dr. Edmond.
Yes, so you're back with me while I invite up my colleagues. I'm joined by Dr. Marilyn Underwood, our Director of Environmental Health, our Consumer Protection Division Director, Beatrix Santiago, our Environmental Health Manager, Jonathan Rubing, and a member of our Tobacco and Substance Use Policy Prevention Policy Team, Don Tran. And one of the things that's so important about our tobacco prevention work and ways in which it differs from our harm reduction work from illegal drugs is that it really takes collaboration both within and without the county to help reduce access, especially youth access to tobacco products, as well as collaboration throughout the public health department, relying on our environmental health branch for the enforcement piece and on our healthy communities branch for policy, education, advocacy, and collaboration with partners. So you have the full report in front of you, and we'll be happy to take any questions. Thank you.
Thank you. You have anything to add, or I will open up the public for comments.
Thank you. No, we're ready to answer any questions you might have. Thank you, though.
Thank you. How many in the public would like to speak on this item?
No request to speak on item 9.
Okay, let's go and close the queue on that. Yes, Vice Chair, you have any questions?
Yes, thank you. Thank you for the report. And I remember this effort from back in the day when I was on the Mountain View City Council over 10 years ago. There was quite a push to have cities adopt ordinances, I noticed in the report that it looks like actually only 3 have done so, and so I was wanted to ask what your plans are to expand those partnerships into the cities and maybe kind of. I remember it was a big push back then, and we had considered it at our council. And I can't remember if it was the Great Recession. Something happened and things sort of died down. So what can we do to reignite that effort?
Sure. Well, I'll take a first pass, and then I'll probably look to Mr. Tran to jump in. I think because this report focuses on the enforcement piece, where we have explicit collaborations with 3 cities, it belies the actual breadth of the deep collaborations we have with really every city in our jurisdiction. There is some level of tobacco prevention policy in every city in our jurisdiction, as well as the model ordinance we have as a county that affects our unincorporated areas and the 3 cities that have adopted the most up-to-date version of the model ordinance. So Don, can you share more about work we're doing with the other cities that fall outside the enforcement agreement but that are making progress?
There we go, we got it. Thank you for your question, Supervisor Abekoga. So sharing how our program works with other cities outside of our partnership program, we constantly provide technical assistance and in some cases grant funding towards cities towards implementing their own respective tobacco retail licensing programs. Regarding your question about the city of Mountain View, back in May of 2025, so about a year ago, City Council did indicate interest in joining the county's partnership program, and that interest is still being explored right now and being studied by staff on the city side. So we're still currently in negotiations and talks with them.
And if I may add one more piece, I think just another example of the progress we make even without the explicit partnership of the model ordinance. Two cities, San Jose and Gilroy, just this year, in part in response to the findings of the Latino Health Assessment, moved forward with a moratorium on all new tobacco licenses, which is one of the most powerful, progressive, effective steps that a city could decide to take to say, while we get a handle on an issue, especially around youth tobacco access, and in some ways the complicated intersection with cannabis and alcohol and nitrous oxide, saying no more new tobacco sales. We will find other ways for our small businesses to thrive. We will find other ways for folks to access other food or things that they can purchase while we figure out what is the right policy for our city.
Yes, that's great. I remember talking about that, and that was my question. Is we have tobacco, we have vaping, we have cannabis, and so right, and I don't think we can pick one or the other. It's sort of all of the above, and so what is the intersectionality of these initiatives? Is my question.
Sure. So Don is part of a small but mighty team that looks across the entire county of policy, really when it focuses on legal but harmful drugs, especially those that are regulated at the state level, like tobacco and cannabis and then alcohol, also at the federal level. I think we find a need to sort of engage at almost every level of possible intervention, everything from collaboration with community partners who do education in schools and with youth about the harms of vaping, the harms of cannabis use. We engage at the policy level, the state, to educate around closing gaps, for example, in sort of tobaccos that are not technically flavored tobaccos but function similarly. They're considered sensations like cooling or tingling sensation tobacco and nicotine products, as well as clarifying information around things like flavored tobaccos as the list expands and as our tobacco companies unfortunately innovate faster often than government can regulate. When it comes to emerging substances like nitrous oxide, or we're hearing about new ones like kratom, what's tricky here is there is no umbrella regulation system the way there is for tobacco and cannabis and alcohol. And so this is causing, again, one more level of frustration where the salespeople are innovating faster than government is, but we are working very hard to try to get out ahead of it, including some important legislative conversations I had in Sacramento recently, collaboration with the California Health Executives Commission to try to bring that same state level of engagement and regulatory infrastructure to new substances. And so while you're seeing present a patchwork of ordinances and attempts at enforcement to tamp down things like abuse of nitrous oxide based on how they're sold across the state, we are working to understand the risk to our community members, educate about the risk to our community members, and then advocate ultimately for statewide legislative and regulatory structures that will help us get our hands around the issue and stay out in front of it.
Great, thank you very much.
Thank you. I just say thank you for the good work on the report. I have no further questions, and keep up the good work. Thank you very much.
Thank you.
And can I have a report?
Yes.
Of a motion?
Happy to make the motion to accept the report.
And I'll go second that. Let's take the vote.
Vice Chairperson Abekoga?
Aye.
Chairperson Lee?
Aye as well. Thank you.
you.
All right, moving to item number 10, which is considering the recommendations relating to the Behavior Health Pavilion. And let's see, of course, Paul, you can do that as you see our facilities director, Jeff Draper, as well.
Thank you, Supervisor Lee. Jeff Draper, Facilities Director, will give a brief update.
Good afternoon, Chairperson Lee and Vice Chairperson Abikoga. The project continues to make progress. It's slow and aggravating, as we reported back in January, more so than we would like. The team has been working hard to overcome the fire life safety final inspections, if you will. That's really what's going to be going on for the next 2 to 3 months, is finishing up the fire life safety inspections, along with some fire safety doors and a few other details related to the air conditioning system. That's really what's driving the project at this point, and I'm ready to take your questions.
Thank you. Yes, Paul, you have anything to add?
Other than the target date to see our first patient is August 5th, correct?
Yes, that's correct.
The tentative date for a potential ribbon cutting is now August 5th, you're saying?
No,
No.
it can be earlier. We're very much hoping for the end of June while board is still in session.
Right. I think that would be great if we could do that.
Yeah.
I guess the question is, hopefully by then we don't need to wear a hard hat at the ribbon cutting. Is that what the concern was?
Yeah, you should not have to wear a hard hat at the ribbon cutting. That's more of the groundbreaking side of it.
Right, exactly. And the shuffle.
That's right.
Okay, good. So end of June is still what we're shooting for right now, you think?
For the ribbon cutting.
Anything we might need help on from the state? Is there anything that we could use our contacts in Sacramento to ask some of our state authorities to help speed up the process? Just checking.
The regional compliance officer, the state office, we've been in touch with all of them, and they've been working closely with us and trying to figure out how to expedite this fire life safety inspection to the max degree.
Exactly.
But of course,
Yeah.
our contracting team and our site coordination team own part of those responsibilities, but they have worked out a strategy to move it forward.
Right. Now, so the August 5th date, you believe, would be the date that we actually could open the door to serve clients? Is that
Yes.
what we're talking about?
Yes, that's correct.
Okay, good. All right, let me see if any public would like to talk about this.
For item 10, Behavioral Health Pavilion, there are no requests to speak.
Go ahead and close the queue. Vice Chair, do you have any questions? Do you want to have a motion?
Happy to make a motion to accept the report.
And of course, I'll second that. I just want to say thank you again, Jeff, for the update. Like you said, it's slow, it can be aggravating, and just like any construction project, then we all have their different challenges. Nothing is ever, quote, done on time. And of course, the budget as well sometimes costs overrun and whatnot with all the change orders. But I just want to say thank you for being on top of this. As you recall, my former colleague, Supervisor Comedian, has been extremely concerned about the dates on this issue and have been pushing really hard on the timeline. I want to thank him for that pushing, but I certainly wants to echo those same sentiments. Let's, full speed ahead let's get to the finish line.
Thank you, Supervisor Lee. It's my pleasure, and I do feel the former supervisor's presence in this project.
Absolutely. Like Yoda. All right, thank you very much, Jeff. And with a motion, a second, let's take a vote, Jess.
Vice Chairperson Abikoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Thank you. Moving to item 11, which is our CVH. Paul, anything else to update?
Supervisor, nothing more to add at this point.
Okay, good. Dr. Redmond?
Thank you. I have 3 brief items for the health officer report today. The first is to draw your attention to our contribution to the joint ledge file describing, at the supervisor's request, an update to our community health worker program for the continuation of the Asian Pacific Islander Community Health Worker Program that no longer has direct county funding, but persists in many of its components and persists to have public health support with coordinating. So ACI now is the lead agency really owning this project, and so I have the sort of benefit of representing what is mostly their fabulous work, including applying for sustaining multiple examples of non-county funding in the form of grants that are allowing much of the work to continue, facilitating a network of the agencies that provide the direct community health worker services, and continuing to enhance the ability of those agencies to achieve funding independence by especially becoming Medi-Cal reimbursable or CalAIM, eligible for some of the CalAIM related benefits for community health workers. But public health continues to work to support them, especially with respect to technical assistance for the network of providers. So in just a moment after one more item, I'll be happy to take any questions about that you may have. The second is just to report back, since it has been, since before the start of the year, since this body convened, on two public health items of interest. The first being that I want to congratulate all of the county colleagues who helped to make us safely through Super Bowl 60. We are right now in the time frame where if there had been a large public health exposure, such as a measles case in that stadium, we should have heard about it by now, seen our wastewater spike. I shouldn't, you worried I'm jinxing it? So we have been monitoring extremely carefully. The Public Health Department crafted a number of novel monitoring mechanisms and dashboards to help us feel very secure as we made it through the week before, during, and after the event, that we were not seeing any unusual infectious disease activity beyond the already very high flu and RSV and some COVID rates that were affecting our hospital partners. So congratulations to our Office of Emergency Management folks for coordinating all of the many partners it took throughout the county to respond and keep us as safe as we did during that event. The reason I mentioned measles of particular interest is we have already, as a country, seen sky-high rates. I think the numbers today are already over 1,000 measles cases nationally in 2026. And last year, the highest number we've had in decades. Just here in the Bay Area, I believe we've had 4 cases already over the course of the winter. Fortunately, none here in Santa Clara County, although we have had individuals who have been exposed to those other Bay Area cases. And so every time that happens, there is a rush of public health resources dedicated to making sure no one who has been exposed becomes ill and exposes anyone else. And so we continue to keep our eye on the ball there and message community healthcare providers about the importance of vaccination, accurate information about vaccines, their recommendations and where they can be accessed, and how to identify and follow up a measles case. And with that, I'll end my report and take any questions. Thank you.
Thank you. Any further questions?
Yes, thank you. And thank you for the update on the API Community Health Worker Program. I'm happy I had heard and I'm happy to hear that there was grant funding available that will continue the program. But I was just, my question was how our department is planning to continue to support the API Community Health Worker Program while looking at launching, I guess, the Latino.
Yes, so fortunately, there is a lot of synergy between the work we're already doing around the referral from the Latino Health Assessment to craft a proposal for a comprehensive community health worker system that would focus on serving Latino residents, and especially in the areas highlighted in the Latino Health Assessment geographically that need the most support. But so I will back up to say we're halfway through sort of a phase 2 of a 3-phase comprehensive process that really understands what do we have in the realm already of community health workers, in this case serving Latinos across the county, but many of them are also serving people of other races and ethnicities, including some overlap with the groups represented in the API CHW network. And so in that process, we are currently collecting data to understand what is the full landscape of what exists right now. What are the challenges, some of which are resources and financial, but some are logistic or policy, so that we are able to jump in and intervene at every level where we have resources now, and then prepare ourselves to intervene where we don't yet have the resources to do so. So as we come back to the board with, I believe the next milestone will be the quarterly report from the Latino Health Assessment in March. We'll have a partial update on that full study and where we stand. And then later in the spring, we will have the comprehensive report back to the board. We will share a number of findings that already clearly reflect how we can continue to support the API CHW network in crafting something that supports Latinos. Examples like recognizing the difficulty of becoming a certified community health worker, which is necessary to be paid for by Medi-Cal. There are major problems we're hearing from these same groups that do community health worker work in becoming certified, whether they're the languages the courses are offered in, the timing of the courses, access to those courses, documentation status requirements, as well as the actual reimbursements of those. And so there may be both policy solutions we need at the state level to make that kind of reimbursement a reality, and logistic changes to the certification process that we need to make the current policy applicable to people here in Santa Clara County. So it'll be findings like those that will be crafted around the need of our Latino community, but will absolutely apply to our API community as well. So we're working to make sure we don't miss any opportunity to take what we're learning in that Latino health assessment follow-up study and bring it back to our partners at ACI and the network here, as well as learn from ACI and our partners in the API CHW work. Are there unique needs that they're identifying that may not be bubbling to the top in our LHA study, and how do we meet those as well? So the work continues. I think you'll hear much more in probably April. Thank you.
Great. And in particular, the focus on the Medi-Cal billing, I was wondering if that could be a potential source of funding to continue these programs.
It is both potential and a limited source in its potential. I think what we find is, one, the actual reimbursements are often not enough to sustain the program, and so often they need to be part of a funding system for a program. Two, the organization that becomes Medi-Cal billable needs to have a certain level of administrative robustness and infrastructure to be able to be billing Medi-Cal. And then three, the CHWs themselves need to be certified and need to be providing a service that may not be just what that community member needs, but enough to meet qualifications for the reimbursement. And as we were just saying, becoming certified and then hiring a workforce that's certified can be a limitation. And then even if you've got a certified workforce, an eligible billing entity, making sure that community members are receiving the service that Medi-Cal considers billable can be a barrier. So these are all things that we're finding, again, through both the API work, which is part of why we think that even with all of the support of ACI ourselves, I believe only one of the API network members, CACs, has become independently able to bill Medi-Cal, and others are working with ACI to do so. But it's also certainly been apparent in our Latino health assessment follow-up as well. And so I think we're going to need both supportive mechanisms and policy mechanisms to remediate that.
Great. Well, look forward to updates, and please bring them forward here. We can probably help a little bit on the policy side. So,
thank you very much.
Thank you. Dr. Terrell?
Sure. Good afternoon. Nothing to add beyond what's in our written report.
Good.
Thank you.
Okay. And moving to Valley Health Plan.
Good afternoon, supervisors. I have one item I'd like to report. I'm pleased to announce that Valley Health Plans has been certified as a great place to work. So this certification is based on the employees' feedback through the survey that conducted by the independent entity. And receiving this survey means that VHP has been recognized for creating a supported workplace environment, and our employees feel very respected, valued, and proud to be part of the team. So we're really honored to have earned this certificate and hope to continue receiving it every year going forward.
Thank you so much. All right, on that, moving to the last report, which is relating to the federal and state health policy and budget landscape. I believe Bert Margolin from the Margolin Group is here online. Yes, Ms. Margolin, good afternoon.
Good afternoon. I have a relatively brief report for you, which I will now get to. I first of all want to update you on the, make a couple of comments regarding the federal budget process. 11 of the 12 appropriation bills were passed and signed into law this year, which is a notable bipartisan accomplishment in this age of continuing resolutions and sharp divisions between the parties. There's one bill that didn't pass, which has produced this partial government shutdown, the Homeland Security Appropriation Bill. Because 90% of the employees of Department of Homeland Security are considered essential workers, even though they aren't being paid, they are still on the job. So the impact has not yet really been felt from this partial shutdown. Two general points to make about the federal budget process this year. These bills that were signed represent, for the most part, a bipartisan pushback to the Trump agenda. I know most of the media attention is focused on all of the drastic and damaging changes that the Trump administration has been able to push through in the area of health and related social service areas. But in the actual low-key, under-the-radar appropriations process, Republicans and Democrats worked together to actually produce funding levels that are much higher than what President Trump asked for. And even more importantly, most, if not all, of the structural changes that the Trump administration asked for were rejected on a bipartisan basis. An example of that is in the area of health and human services. Secretary Kennedy wanted to get rid of SAMHSA and HRSA, create a new sub-agency, move everything around in a way that would have been very destabilizing. The Congress on a bipartisan basis said no to that. The significance of that is this resistance to statutory changes, even though there's been tremendous damage done through these administrative and regulatory channels. The significance of this pushback is a statutory change is very hard to reverse, much harder to reverse than these administrative attacks, regulatory attacks. So it's worth noting that on a bipartisan basis, the Congress did not make these damaging statutory changes. Second point worth noting is that earmarks were a not insignificant factor in the bipartisan agreement to pass these 11 appropriation bills. Earmarks motivate members, they always have, and they're so popular among members that it's worth noting that on the House side, House appropriators are talking about allowing earmarks this year in the Health and Human Services bill, something that was not done on the House side this year and only in the Senate side. Worth noting for Santa Clara County that there could be that potential opportunity on the earmark front. A couple of other highlights to touch on. Affordable Care Act enhanced subsidy negotiations have, as we all know, gone nowhere. They're still talking, but no progress being made. Republicans are very dug in on not moving forward on this issue. There's a chance of a deal, but it's more likely to become a campaign issue than a bipartisan agreement at this point in time. Impacts already being felt. New enrollment down here in California through Covered California by something like 30%. Another development worth noting is that the threat of another reconciliation bill seems to have been avoided here, at least for the time being. Reconciliation, which is the mechanism that allows for a simple majority in the Senate to pass a budget bill, it was a mechanism used to pass H.R. 1, which did all this damage to the Medicaid program. There was a fear that it would be used again this year. It's eligible for use, but President Trump said last week that he was not going to pursue reconciliation. Now, we know the president is capable of changing his mind, so we're not totally out of the woods, but the very, very narrow margin in the House and recent efforts by some House Republicans to defy the White House and move ahead on matters they didn't support probably persuaded the president to shelve reconciliation for now. The last item I want to mention are two final items. The Affordable Care Act, there's a new regulation put out for comment recently. Every year, Health and Human Services develops a marketplace rule, usually designed to improve the Affordable Care Act. The new proposed rule just recently released may do the opposite of that, in that it may reduce the number of people insured in the exchange system by more than 1 million. Normally, these rules are designed to expand coverage, not produce fewer people being covered. In addition to various changes that might discourage people from seeking enrollment, they also, this regulation, proposed regulation, also encourages catastrophic health plans that sound good on paper, but actually produce very little real coverage for people and are unaffordable in terms of allowing people who have a major healthcare episode to really manage their condition. So that's their focus right now, catastrophic coverage. The last item I'm going to mention is the Center for Disease Control $600 million grant withdrawal that was announced recently, a highly partisan move directed at 4 blue states only. There are lawsuits already filed. There's a temporary restraining order in place to delay implementation. There's a lot of chaos associated with these grant rollbacks because, and this is not uncharacteristic for this administration, as of today, no official letters have actually been sent to grantees. So the judge who approved the temporary restraining order said it's very difficult for him to even deal with this issue when there's not a formal letter of rescission or letter of clawback issued. Those are some of the high points that I wanted to touch on. More than happy to respond to any questions or comments you might have.
Thank you very much, Mr. Golis. I do want to mention, you said that, was it 9 out of 10 bills have already been passed
11
for?
out of
11 out of 10.
11, yeah.
So the one that is still pending is basically related to the Department of Homeland Security, am I correct?
That is correct. That is correct.
Okay, and then at this point, there's no end in sight on this one, correct?
No end in sight. The last time we had a budget crisis like this, the way in part it got resolved is when TSA employees who were not being paid, even though they're essential workers and required to be on the job, began not to show up. So we might be in for a similar syndrome here. On the actual substance of which is the requirements that ICE officers comply with the same standards of behavior that all other law enforcement agencies are required to comply with. The White House is fairly dug in as of today. Democrats are insisting on this standard of compliance. It's possible that there's a substantive deal worked out, but it's also possible that the shutdown ends because of, again, the TSA dynamic or other factors. No one knows. But right now, the negotiations where ICE behavior is the central issue are not going especially well.
In this deal, let me try to understand in terms of the filibuster rules, which is very complicated in the United States Senate. Is this one that they need 60 votes, or can they do it with 50 votes?
No, they need 60 votes, which is why Democrats have leverage.
Right. Okay. Got it. So that's where we are.
Yes.
Okay. On that happy note, thank you very much, Mr. Golan. And I believe this has now bring us to the last item of the meeting today. Am I correct there? Yes.
It is confirming that we have no request to speak on item 11.
Okay. And we don't need to receive a report either, right? This is no. Okay.
Vote's not required yet.
No, not required. So this brings us to the end of the meeting, and we will be able to now adjourn. Thank you to the administration and clerk staff. Next Health and Hospital Committee meeting is scheduled for Wednesday, March the 18th at 2026 at 2 p.m. Same place, same channels, right here. Thank you very much, everybody.
Thank you.
Thank you.